Hi, everyone. I am Jennifer Williams, and welcome to our special edition of Facebook Live Fighting Breast Cancer Together. We are so honored to have with us two guests today, Dr. Michelle Blackwood, Medical Director of Breast Services for the Northern Region of RWJBarnabas Health and Chief of Breast Surgery at Rutgers Cancer Institute of New Jersey, and Maria, a strong and beautiful breast cancer survivor and one of Dr. Blackwood's patients. We are going to talk about everything from diagnosis to treatments to the importance of annual checkups and mammograms. So if you have a question, please leave us a comment below, and please help me welcome my two special guests today, Maria and Dr. Blackwood. Thank you both so much for being here today.
Thank you for having me.
Thank you for having us both. I appreciate that.
Yes, it's Breast Cancer Awareness Month, so you know, it's always important to have these conversations, even though everything is saturated breast cancer right now. We want to make sure that we share, you know, all of the best information with our audience. So Maria, why don't we just start with you? So let's start at the beginning of your journey. You turned 40, you went for your mammograms, and what happened from there?
So when I turned 40, I went for my annual mammogram as was suggested, and it was determined that I had dense breast tissue. So at that point, I was asked if I would come back 6 months later so that they could just compare the baseline that was done at 40 to the one I was going to have 6 months later. And at that point, they told me there were some calcifications that they were going to keep an eye on, and they wanted me to return again 6 months later. At that point, they did a biopsy, and that biopsy came back benign. But I was told that since I had the biopsy that they needed to see me again 6 months after that. And at that point, the scan revealed, and I had just had a mammo at that point, but it revealed that I had a hematoma, or what appeared to be a hematoma, in my right breast from the area where the biopsy was done. So the suggestion was that I go for an MRI. I went for the MRI, and at that point, there was alarms that were set off because my right breast, which is where they were targeting all their attention, was completely fine. It was a hematoma, but it was what was hidden in the left breast that they were concerned about. So they suggested that I have another mammo, and an ultrasound. The ultrasound highlighted the fact that I had some enlarged lymph nodes in my left area underneath my breast. And at that point, the suggestion was to have a biopsy. Mm-hmm. Once I had the biopsy, it was revealed that it was cancer.
Wow. I just think about all those things you went through just to get to that point. And, you know, you bring up having dense breasts. Dr. Blackwood, can you talk to us a little bit more? You know, what does it mean when someone has dense breasts? Am I at higher risk for breast cancer?
So dense breasts mean that your mammogram, which normally shows images that are shades of gray, white, and black, are mostly whited out. So it's like trying to find a snowflake in a blizzard. The dense breasts used to be thought that it was just harder for us to find a breast cancer in those dense breasts. But the reality is that people who have dense breasts, that means they have a lot of elements to their breast tissue that's sort of surrounding the tubes and the lobules, the ducts and the lobules. And those patients actually are at higher risk for breast cancer, sometimes substantially so, depending on the other risk factors that go for breast cancer. However, it doesn't necessarily mean that if one has dense breasts, one is going to get breast cancer. Dense breasts are a term that we now use and utilize greatly when we read someone's mammogram, meaning that the radiologists read the mammogram. It is part of the grading system of the mammogram, thankfully. It didn't used to be. It used to be either you had a benign mammogram or not. And we don't see least cancer or we don't. But now we know that people with dense breasts or dense mammograms really need other tests yearly when they have their mammogram. Screening mammogram means that any woman at any point, or a man, comes in, has a mammogram, they don't feel or see anything wrong with their breasts. It's what we recommend yearly above age 40. And then if they have dense breasts on mammogram, we usually recommend another test. Some people say an ultrasound, which is relatively easy to do. It's a relatively cheap test to do. It's not physically difficult. There's no injection of anything, and it can be scheduled pretty much relatively easily. An MRI is sort of the gold standard for dense breasts or people at higher risk for breast cancer. And an MRI is done obviously in an MRI machine, and it requires an IV contrast that be placed into the arm during the test. That is gives hundreds of images actually, whereas an ultrasound, of course, doesn't give you hundreds of images. And it also gives you contrast, so you can see what we say lights up or doesn't light up. And it's the lighting up and also looking at the lymph nodes under the arm that really lets us know maybe there's something going on in this breast.
Well, it's just so I feel like there's just so many things that we don't always, know about and hear about. And so Maria too said that she was under, a surveillance program. Dr. Blackwood, can you tell us a little bit about our breast cancer risk management program that we do have here at Cooper and Barnabas?
Sure. Yeah, sure. We're really lucky to have, we instituted a number of years ago now, a high risk clinic, meaning that patients who are found to be a lifetime risk of breast cancer greater than 20%, family history, have a gene that causes breast cancer, any of those can come in, get their images managed by us, meaning myself, the other surgeons, the PAs that are in our program. And you can have mammograms, MRIs, ultrasounds, and then a breast exam once or twice a year. We also talk about how to prevent breast cancer in the high-risk patients. So some patients take a pill that can reduce the risk of breast cancer. Some patients will be also talk about surgery if they're very high risk of breast cancer. There are a lot of gene mutations now that we are recognizing that really do and can increase one's lifetime risk of breast cancer. So those patients sometimes choose prophylactic surgery. This is I think a well-received program because a lot of patients don't understand and are not sure where to go and are not sure they're even high risk. So one can go online to something called GAIL Model Risk Assessment, GAIL Model Risk Assessment, and plug in some very simple answers to questions and find out if you are at high risk. The normal risk for American women for breast cancer in our lifetime is 12%. So pretty much anything above 20% lifetime risk puts one at higher risk. Those patients really do need to have their mammogram, ultrasound, whatever else testing, and breast exams with people that do this kind of every day. So a lot of our gynecologists work with us in conjunction to manage these patients and make sure that they're hopefully, if they, God forbid, develop breast cancer, then we find it at a very early stage. And those patients are automatically in our program and get seen right away.
And Maria, so now you're under surveillance, you've gotten your diagnosis. What was your initial reaction?
So honestly, while I was under surveillance, I knew what the doctors were thinking. And the diagnosis came from Dr. Blackwood after I went to her for kind of a stern talk. I know she won't think it was stern, but it was, she kind of sat me down and really had that heart-to-heart with me because it was being recommended that I go back in the MRI machine for a biopsy. And at that point, I just felt like the term I use, pincushion. I was just being poked and prodded, and I didn't know really what was going on. I was scared, but I knew that I needed someone who was an expert in this field. And when I went to see Dr. Blackwood, her recommendation was that I get a biopsy of my lymph nodes, as the ultrasound and the MRI that I had were basically, like she referenced, lighting up and showing an area of concern. So she graciously got me in to get a biopsy the same day that I met her for the first time. And she called me, I guess it was about a week later. I had an appointment with her the next day, and she knew, just based on our first meeting, the type of person that I was and that I needed my family. And I promised I wasn't going to do this. She asked that I come with my family because there were proteins and it was cancer. I am a reading specialist. I teach elementary students who are struggling readers. I was in my classroom. It was December 18th of 2018. And I was in shock. I was also in disbelief. There was a part of me that kept saying, they're lying, they don't know what they're talking about. Just basically, I knew best, and this wasn't going to happen to me. How could this happen to me? This can't be happening to me. So there was a lot of denial. But I walked myself down to my principal's office, and he saw the look on my face, and I was very open about the screening I was going through. And there was like this feeling in my gut. I just knew something wasn't right. My period was irregular. There were a lot of things happening with my body, and I just couldn't pinpoint what was happening, but it was like my body was sending off these alarms. And I walked down to his office and I told him the news that I had just received on the phone. And he said to me, I'm going to drive you home. And I said, I'm going to call your husband. Like, didn't know how to give me, the support, didn't know how really to help me at that point. But I just said to him, I need you to listen, because I'm going to be normal. While they're telling me I have this, I'm going to be normal. I'm going to come to work every day. And that was my goal. It took a while for me to accept and be able to say I have breast cancer, because there was a part of me that felt that that wasn't who I was. And I just wanted to be me. So I did everything I could to be the reading teacher, the mom, the wife, the sister, and keep things as normal as possible, even during chemo.
Well, we think that you're so strong and incredible for being here and sharing, you're here and you're telling us this story, and that's beautiful in itself. And you and I spoke a little bit before too. Talk to me about the word trust. You did go to a few other places, but you ended up choosing Dr. Blackwood and CBMC. What was it that made you, choose to get your treatment here?
So I think I'm a very spiritual person. I look for what I consider signs. And Dr. Blackwood, I connected with her immediately when I saw her. There was this feeling of I'm in good hands. I know I'm in good hands based on what I've heard, what I've read about her. But then for me to actually sit in front of her, I could feel it. She was genuine. She was supportive, comforting. She hugged me, which I know that sounds crazy, but the hugs are so important. I was not a number. I was a person. She totally got me right away. She knew that I needed my family to be around me when she was giving me some, very hard to digest news. But trust to me is so important, because you really build a relationship with your doctors. They're people that you see, not just that one occurrence. When you have a diagnosis like breast cancer, you have, depending on your course of treatment, I could have been at the doctor's 3 to 4 times a week if my numbers were off. Phone calls were being made to Dr. Blackwood's office. I was calling her staff. And during that process, you bond with them. They become part of your family. And I needed that. I did not want to be a case number. I wanted to be Maria, the person that they knew, as a wife, as a mother, most importantly. I remember Dr. Scapitula was the person that Dr. Blackwood recommended to be my oncologist. And I made it very clear to him that I could not leave my children. There was no way my husband could handle raising them without me. And that I needed him to smile and to hug me. Because I knew I was getting that from Dr. Blackwood. So I needed that to, he needed to understand that too. And I had a hard time, because I don't know if it was just his presence, but he looked at me, and I know he probably thought in his head, this woman's out of her mind. But he said, at first he said very calmly, he said, I smile on the weekends. And I said, but I don't see you on the weekends. And then, something he said also stayed with me. And this goes to show you how important trust is. I knew he was my person when he said, very gently, looked to me and said, I want you to think of this as a really bad infection. And with the right antibiotics, we are going to clear this up. And I needed that because I had a really hard time saying I had breast cancer. And I think he knew that. I was, against ports. I just wanted to be, I kept saying normal. And at that point, I built a relationship with him. I knew he came highly recommended from Dr. Blackwood, but trust is so important. And I continue to trust them.
Yeah, I can get that. I see him saying something like that too. And he's very calming, which you always need to. And we need to surround ourselves with the people. And okay, so Dr. Blackwood, after this stern talking to with Maria, what was your approach then? You kind of said you had a feeling, and then, now what happens next?
So when I met with Maria the first time, I had the benefit of she'd had her imaging done. So that always helps. So I think it's really important as a physician and the physician-patient relationship that we try and meet the patient where they are. I already went into that room before I'd even met her. I'd seen her images on my computer in my office. And I knew that I was going to recommend a biopsy of the breast and of the lymph nodes. I also had a feeling that Maria felt, like she said, like a pin cushion, and felt like all this was over testing. And I get that. First of all, number one, nobody wants to be a patient. Let's face it. None of us want to be a patient. I've been a patient, not particularly for breast cancer, for other things myself, and it's not an easy thing. Number two is, I think it's important for us to have a dialogue, for the doctor and the patient to have a dialogue where we can meet, meaning that, it's like I said before to Maria, it's not like I just see a report and then I make a recommendation. Okay, you need an MRI guided biopsy, let's go. It doesn't work like that. It's physically demanding on the patient. There might be a fear of pain or claustrophobia. And she asked me a very good question. She said, is there another way for this to be biopsied? And we came up with another way, and we did it that day. So I think it's important to have those conversations and to be heard as a patient, which I think is a validation, but it's also, as a physician, let me think outside the box. Let me think, oh, you're right. Okay, let's try an ultrasound guided biopsy. I bet we can do it that way. And so I call it, I'm not sure it was a negotiation. I would not say I was stern. I think I probably said something like, if you were my sister, this is what I would want you to do. I did say that. And I thought there was no downside to finding out that day what we needed to find out. I totally understand when a patient thinks we're overdoing it. I get that. And I get the fact that nobody wants to be a pincushion. Nobody wants to just be put through tests just to check a box. But I felt so strongly, and I think that came across to Maria and to her family, that I really felt like this was a very important thing to find out. I did give her an option. I didn't say biopsy or no biopsy. I did give her an option like I would give my kids. You can have a bath with bubbles or a bath without bubbles, but you still take the bath. So I said to her, we can either try a biopsy today or we can try it another day, but I think you need a biopsy. Mm-hmm. And that
I very quickly responded, just get it over with today. Please make it happen today.
So I took my opportunity. I ran out of the room, made sure the radiologist was on board and didn't go home yet, and made sure we got that biopsy that day, because this was our opportunity to make sure that I was hoping, of course, that this was going to be completely fine. And I was sorry that it wasn't fine. But I also knew the quicker we found out, the faster we can get her to treatment and the faster we can make her better. So time is of the essence to some degree when it comes to cancer. It's not immediate, but I do think that, I think there's some lessons to be learned here from the patient and the doctor. Have the discussion, talk about what your fears are. Are you afraid of the MRI machine? Are you afraid of the gadolinium? Are you afraid of being face down? What are the limitations in your head? And as a physician, I think we have to learn, okay, let me think. Let me see if we can do it this other way. I even remember saying, if you do nothing else, let me biopsy those lymph nodes. Am I right?
You 100% said that.
So that was, again, a negotiation, because I thought, even if I get the diagnosis from the lymph nodes, we can back into the breast tissue at a later date. So I knew we could reach the lymph nodes that day. So I think as a physician, you also have to take whatever the patient can give you that day. You know, you can't make everybody jump through hoops as a patient. Everybody is a person that's coming to this with different expectations and different fears and different understanding. Sometimes it's interesting, patients misunderstand what I say about how we're going to biopsy something or how we're going to do a test. And then I realize maybe I just haven't been as clear as I should be, and I back it around. So I remember the room that I saw Maria in my office. So I remember very clearly trying to figure out a way that she heard me and I heard her, and that we could reach a mutually beneficial understanding. I don't want to make you cry. I'm sorry.
I'm sorry. I just,
You're gonna make me cry. And then
you are
an
an angel, Dr. Blackwood. I don't know if you know that, but you are. You really are.
Well,
I mean, that's the difference between a doctor who is just a practitioner and a doctor who's a human. And she is a human and understands that her patients are people.
Yeah. Okay, we all can't cry. So
yeah, you can't get this crying on Facebook Live.
it will be funny memes all over the internet. But I do want to touch on Marie, you talked about wanting to feel normal and wanting to be you and being a mom and being a wife and all of the things. And then Dr. Blackwood, you and I have talked before too, and you were just saying to me that you see almost 25 plus people probably before you get to surgery or treatment. Maria, tell us about all those people, those 25 people in that line you met, your family. How important was that support to you?
So, when you make a decision, it's almost like you've decided this is, your course of action with these people. And I call it like, you don't get to choose who your family is, but you do get to choose who your doctors are. And it's such an important decision. From the start of this, you see various technicians who are running all sorts of scans, CT scan, MRI, the scan that I never want to have again, which I swear I can't even remember the name. You go into a PET scan, PET scan. I'm like on FaceTime with my husband who can't be in the room because I'm radioactive. But you meet all these different technicians along the way. And then doctors, there are nurses, people who are drawing your blood, people who are administering infusion. You get to know people because you don't just, unfortunately it's weekly visits, and these people ask you questions about your family. They ask you questions about how you're feeling, what your job is. I remember bringing lunch to the infusion center, sitting there, almost like it was normal to eat with people as I was like having chemo injected into my arm. But it means everything to have that support and to have people who truly care about who you are. There was a day where I had missed my chemo treatment because my numbers were down. I had gotten pneumonia and I couldn't have chemo. And the nurse looked at my file and called me and said, I just wanted to make sure you were okay because you're usually here on Fridays and we haven't seen you. You don't get that everywhere. And it's so important. Dr. Blackwood has a woman named Kelly on her staff, and the text that I would get, she doesn't have to do that. I have her personal cell number, the text, how are you feeling, checking in on you, sending me just messages of inspiration, motivational messages that sometimes you do need. But to answer your question, having the right people around you is everything. It's everything. And that's really why I also chose to go to work. It was so important to me to be normal, but also to surround myself with positivity and people who I know had my back. People who, would give me in the morning the support that I needed. I had a friend who would come to my house and make my daughter chocolate chip pancakes because she knew I couldn't. You need to surround yourself with people who will support you.
That's wonderful. And Dr. Blackwood, on your end, on the clinical end of things, like, can you tell us a little bit about the multidisciplinary approach we provide here at Cooperman-Barnabas?
Sure. We're very blessed to have as many good clinicians and physicians and PAs and people like Kelly Delasco that you can possibly have. I have our office literally was built with a secretary and myself, and now we have over 25 people in it. And one of the things, I've hired people to work in my office that are teachers, that are have worked in all different fields. And one of the things that the first thing we usually say to them is, as long as you're kind to my patients, that's really the number one thing that I need. So in our office, just alone, just to get to the breast surgeons, you will have encountered a schedule at the mammogram machine. You have the mammo, you have the mammo tech, sometimes the radiologist, the ultrasound tech, maybe the MRI tech, back to the radiologist, maybe a different radiologist for the biopsy. Then you have to get a scheduler in my office. Then Kelly is a godsend, a true angel. She runs our place with such care and charisma and an operational fortitude like no one I've ever seen. You need someone like that. And then we have our PAs, our physician assistants are kind and caring and are there in the office and can answer questions. We have nurses that help with any medical issues or scheduling. We have surgical schedulers. But I have counted, by the time a patient gets to the operating room just for one lumpectomy, they may have come in contact with over 25 people that work for Cooperman-Barnabas. And that doesn't even include the cancer center doctors. So the medical oncologists, their nurse, their techs, their secretaries, their people who are giving the infusion. We're talking radiation oncologists. We have radiation oncologists, their techs. They have a physicist that most patients don't even know is there, a full-time physicist that actually calculates the amount of radiation, make sure it doesn't go anywhere else other than the breast where it's supposed to. So they have all these people that take care of one patient with breast cancer, one. So you have close to over 60 people involved to make sure one person is cancer-free and survives. That is an incredible number and amount of manpower and effort and love. And there's one more thing, because Maria brought it up, spirituality, and I'm going to bring it up. In the operating room, sometimes most of the people we found out in the operating room say some sort of prayer before they go into the operating room. And many of us say prayers before while we're scrubbing. But the other thing that I found out is that in our breast tumor board, many of those doctors and nurses and pathologists and geneticists, some of them really also pray in their own faith. And I love the idea that they're all those prayers for this patient. I mean, that's an incredible amount of good energy, whether you believe in it or not, coming towards that patient. And the patients don't even know that occurs. Yeah. And it's not even a group event, but it is truly meant to take care of that patient. Maria, I am beautiful. Crying anymore.
I knew Dr. Blackwood was a spiritual person because she did pray with me. I don't know if she remembers that, but I do remember that.
It's beautiful. And I love that you talk about all the people here, because, you know, we are a team, and it's so wonderful to have all of that positivity going your way, and all of our resources that we have. We're here for you. We want to stress that, and we want you to feel that way. And I'm so glad, Marie, that you did feel that way when you came here, for sure. And
I did. I have an extended, I'm sorry, I said I have an extended family.
That's okay. Yeah. And let's get a little, technical for everyone, a little more. Let's give them like the information they need to know. So, what are some, Dr. Blackwood, what are some risk factors? What are some preventative things that we can help women, possibly prevent breast cancer, or, help them in the long run?
So hopefully we can stop with the tears for a little while.
Yeah, so let's get to the
So let's face it, the number one risk factor for breast cancer, unfortunately, in this country is just being a woman, American women. 1 in 8 women will have breast cancer. I mean, Katie Couric just came out with the fact that she was diagnosed with breast cancer in June. None of us are immune. Mm-hmm. So I think that vulnerability and that acknowledgement can help people, because you're not alone. There's a lot of people and resources, thankfully, that are going towards this. So risk factor number 1 is being a woman. Risk factor number 2 is sometimes there's certain things you can prevent, certain things you can't. You can't prevent who your parents were. So sometimes genes cause breast cancer. There are certain things that go into your makeup. So meaning your physical makeup. So if you were exposed to radiation from a prior cancer, or like if I had a patient with Hodgkin's lymphoma in the past, she might have had that when she was 19 years old. I don't mean Maria, I mean other patients. If a patient I had patients back in the day from Chernobyl who had been exposed to radiation. If a patient has certain lifestyle characteristics, that certainly can put them at higher risk. We know that smoking for sure causes cancer. We know it causes many different types of cancer. We know that regular alcohol use can also cause cancer. So we do ask women to limit the amount of alcohol. I think, many women hear, oh, I should have a glass of wine a day. That probably is not the right advice for women. Then they hear it for their heart. And I understand that's been out there, but the reality is regular use of alcohol seems to increase one's risk of breast cancer. We don't know about marijuana use. Certainly marijuana use is on the rise. I have no proof of it, but we do know that some marijuana is made from the estrogen part of the plant. So we are concerned about that. That's more to be studied and more to come on that. We know that delaying childbirth until what we think is normal. A lot of women don't have children until after they're 30 years old. That can increase one's risk. There's other things that we can't change. When you started your periods and when they end can be relatively long. So if a woman get her period when she was 8 and she's continuing to menstruate into her late 50s, that increases one's risk. So there are some things we can change and there are some things we can't change. Certainly postmenopausally, we know that if women are normal weight and have normal activity levels and exercise levels, that can reduce one's risk of breast cancer. Having said that, I try to emphasize to most women that there's nothing you did or didn't do that is to be blamed for this breast cancer. I had a woman come in the other day crying because she eats cheeseburgers and she decided that cheeseburgers caused her breast cancer, or the Mars bar she ate or the chocolate she ate causes. It's nothing we did or asked for. Breast cancer happens. I think it's for some reason, maybe a cultural phenomenon that women blame themselves for cancer. I don't know why. I can assure you that most men do not blame themselves if they get prostate cancer. So I think we need to get rid of the blame game and concentrate on how to make our lifestyle as healthy as possible. So those are some of the risk factors. Again, we also have these statistical models that we can use too. And we can find out, do I have dense breasts? When you have your mammogram, ask the radiologist, do I have dense breasts? Ask your gynecologist, what does it say in the report? That is a risk factor for breast cancer. So I think there are definitely things that we can assess and then tailor our risk towards, meaning do the Gale model risk assessment, do the Tyrer-Cuzick one that's online, Tyrer-Cuzick. That can help determine your risk factor. If your risk factor really for a lifetime is 20% or greater, come on in, see somebody, find out, is that truly it? There are a lot more tests that are coming out in the future to look for breast cancer, not just mammograms, MRIs, or ultrasounds. There are blood tests that are going to be coming out in the future. There are other nuclear tests that are going to be coming out. There are even a different type of mammogram that's going to be coming out in the future. Again, not necessarily ready for prime time right now, but something to keep in mind. If you have a fear of getting a mammogram, talk to your doctor about that. Some people say it hurts. I usually tell them to take Tylenol or Advil the hour before they come in if it hurts. Don't get your mammogram the week after the week before your period. Try and do it the week after your period. There are tricks to the trade here, and we can help people try and assess that. I'm not saying that any of these tests are perfect. I'm not saying that being a patient is something that any of us want, but it's one of these things you just have to do. I know that since the pandemic, a lot of people have put off having their mammogram or their screenings. It's time to come in. And God forbid we find something, do not panic. We're here. We've got this. We have a full service breast center, great radiologists that know how to find out what we're dealing with, and then we can make it better. I think part of the anxiety when you're a patient and you find out your cancer, Maria, maybe you can tell better than I can, but I think part of it is not having a plan, feeling like you don't know where to go, feeling like you need that anchor and you need that team to help you make some decisions, because there usually are a lot of decisions to be made.
She's absolutely right with that. You know, you feel like you're in limbo for kind of a period of time when all the testing is happening. And then there was this calmness that kind of came over me once I knew what I needed to face, and I kind of clumped it. You know, I had to have 4 ACs. They call that drug the red devil. So I got through those 4 ACs. You know, the first AC was a really big one. It was very hard for me to accept the fact that I was going to Barnabas to get chemo. I remember my husband, I think he really like shoved me in the car because I was ready to run away, and just begging him, don't take me there, take me somewhere else. When we got to the hospital, my sister was there and my brother walked in a Rocky Balboa costume, signifying that I was a fighter and we were going to fight this together. So you need that. You need family, you need people around you who are going to help you get through those milestones. I got through those 4, and then came Taxol, and there were 12 rounds of that. And then you get through those 12 rounds and you're like, okay, what's next? You know, and then you got a little break. And then I got to see Dr. Blackwood, had my surgery, got a little break. And then the next 30 rounds of radiation came. And I tell you, you just check those things off, and you do take them in kind of clumps. And thankfully, you know, this December will be 4 years since I've been diagnosed, and I am cancer free. I do take an estrogen suppressant called exemestane, to help, you know, keep the cancer away. I am in menopause because the chemo knocked me into menopause, and I know that's a good thing. So thankfully, you know, we have all these great people, one that I'm looking at right now, who are there along the way to just guide you through those, you know, I call them almost benchmarks, as I call in my reading world, to get you through each of those kind of strides that you need to get through. So I'm very grateful for that, because you do need an education. It's an education that I really didn't want to have. But I have it now, and I'm hoping to use it to help others, to get them through each of those legs of their journey.
I'm glad that you said that, because that was a wonderful segue. It's my last question for both of you. So Maria, you can go first. And Dr. Blackwood, I'm going to ask you too. So what is your best advice for those who have been diagnosed?
Acceptance. It will come in time. The angry stage is normal. You'll get past it. You'll find strength that you never knew you had. And I think it's important to keep that positive mindset. I definitely held on to my faith. I still to this day sleep with rosary beads and a cross that just makes me feel safe. I think that everyone has something that will help them get through, and you have to find whatever that something is. But the mindset, keeping the normalcy helps with the mindset. You know, someone told me, oh, you should stay home and journal. I'm thinking, that's not going to be good for me. There is no way I'm going to sit home and write about the fact that I had breast cancer. No, that's not what I want to do. So I think staying true to who you are, not allowing the cancer to change who you are, even though it does. You fight it as much as you can, and then you come out stronger. And there is a new you that emerges. And I'm trying to accept that person right now. Physically, definitely accept the beautiful person that you become through the journey. And I think, you know, surround yourself with the people that are going to support you. That is so important. Surround yourself with the doctors that you know you can trust and that will be there for you, not the cancer patient, but for you.
Dr. Blackwood?
It's hard to add anything.
Yeah.
Hard to add anything to that. Maria said it so beautifully. I think a couple things. I see people for second and third and fourth opinions. I think that, you really need, and I tell this to patients, you have to go where you feel comfortable.
Yeah.
If this is not the place for you, the beauty of where we are is we have other doctors that can help you as well. You have to feel at peace with your decisions because there are decisions. And you also have to understand there's a grieving process. I think it's not just the disbelief in the beginning, but there's a true grief, and you kind of have to go through all those stages of grief to kind of come out on the other side like Maria is doing. Your old life is not the same as it was. You're not the same, you know. I think when you go through something as life-changing as cancer, you must accept it and move through it. You never forget it. You never, you know, some people say they get thankful for it. I don't know if that's sometimes appropriate for people. I think it's more like, I think when you have grief, you have to acknowledge it. And whatever way that works for you to acknowledge it is based on you and your life and your family. So some people like Maria moved straight forward, had great support. Work was a salvation for her. It doesn't always work like that for patients. I have patients who want to go to work but can't physically do it. I think that you do have to at some point get to where you do acknowledge and go with the flow, so to speak. You have to acknowledge the timelines. It is literally, for a lot of people, it's a 6 to 10 month timeline for us to cure this cancer. And that is tough. Interestingly enough, when that 6 to 10 month timeline is over, where you're not seeing a doctor or nurse every week, some patients have more anxiety then because they're not getting the affirmation. They don't feel like they're doing anything. They are doing something, particularly if they're taking an anti-estrogen pill. But they have to understand that part of it's kind of like growing up. You get to walk out on your own a little bit. We let go of your hand a little bit. So people do graduate on, which is the best feeling in the world as a doctor. It's great to see people at the grocery store and they look at me and they go, I know her. I just don't know who she is anymore, which is, I know who they are and they may not remember me, but I'm good with that. That means they've moved on beyond a cancer diagnosis. So I don't know why you have to acknowledge it and grieve your former life, but you do. It's just part of getting better. And the people who pretend like it didn't happen, just sometimes don't get better.
And I really honestly, just to kind of extend that, I think that's why I'm here. I think during it, you try to suppress it and pretend it's not happening and you just get through it. And then you realize once it's over, like, oh my God, what just happened? Like, how did I just go through that? You know, when you look at yourself in the mirror, and even though the hair is gone and eyelashes and the eyebrows, that all comes back. But there's a part of you that, you know, has changed. And I think once I accepted the fact that I had breast cancer and realized that I could use that platform to help others and to really, you know, give back some of that knowledge that I gained while I didn't want it. I do have the knowledge now that it can help others. I think that's part of your therapy, is to really like do a 360 and come back and say, you know what, I'm ready to help now. I had this, I went through this, and now let me see what I can do to make this horrible thing, you know, become a positive in my life. And I think this has been very therapeutic for me. So thank you.
Well, and I think that's a good place to end. And I want to thank you both so much, Dr. Blackwood. I think the world of you, and Maria, I'm so glad to have met you. And thank you for sharing. Now you're going to make me emotional, but thank you for sharing your story with us. And, you know, we hope that this little Facebook today could, you know, just help you or encourage you out there. And don't be scared. There are people out there to help you. these wonderful women in front of me. So it is Breast Cancer Awareness Month. So we want to make sure, keep checking back our social media all month long. We're going to share resources and other patient stories about other wonderful survivors out there. And if you are at the mall, you can see Maria. She's got a little display. So take a little picture with her. And also we have some selfie stations. So if you want to take a selfie and you tag us, you could be entered to win a prize. So that's like something exciting we're doing this month. So go to the Short Hills Mall, take a selfie, tag us. And don't forget to make your mammogram appointments. We're going to tag that link and pin it. It's rwjbh.org/mammo, and make sure you just stay safe and healthy. And I thank you both so much again. And we'll see you all next time. Thank you so much.
Thank you. It was great to see you.